Well, I think we've kind of got there with our anti-inflammatory medications. Most of our, what I would call the top end, top tier anti-inflammatories are almost there in terms of suppressing relapses and focal MRI activity. That's new T2 or GAD-enhancing lesions, and we've kind of reached a ceiling in terms of that. But beyond that, there's still clearly lots to do, because a lot of those patients still go on to develop progressive disease. Their disease gets worse, their brains shrink at a more rapid rate. So we're clearly going to have to go into an era where we use combination treatments. In other words, we're adding on treatments to our anti-inflammatories to target those processes that I call smoldering MS. In other words, can we neuroprotect, stop those axons degenerating? Can we remyelinate them if there is remyelination to be done? And can we restore, in other words, axonal sprouting, synaptogenesis to try and restore function? And I think we're going to have to start thinking quite laterally when it comes to neurorestorative therapies, because we're going to have to start incorporating insights that have come from other fields, particularly spinal cord injury, for example, of using exercise or neurorehabilitation to try and promote recovery. So a long way to go, but I think people with multiple sclerosis should not be negative about this. We've really come a long, long way since the early 1990s when you had no treatments. And we're beginning to actually talk about therapies where we are actually causing restoration of function. And there are some trials going on now with remyelination and neurorestorative therapies, where back in the 1990s that would have been considered science fiction. So I think the innovation cycle has moved quite rapidly. I mean, for people with MS, they may say that's too long, but I think, in terms of where we were 20 years ago, 25 years ago, we really come a long way.